Hi, everybody. This recording is going to help you get through your hopefully last snow day of the year and help make sure that we can maximize the class time that we have when we return. So as promised, I'm going to give you some information in today's lesson about um, different psychotherapy approaches. These are described in a couple different modules in your textbook, but the information I'm going to share with you here actually some of it doesn't appear in your textbook because your textbook doesn't cover a couple of these psychotherapy approaches. My plan is to break this video down into two parts just to, I don't know, for best practice in terms of video recording. Shouldn't keep it too long for people. But the first video will cover psychotherapy approaches that are on the front side of that gigantic grid sheet that you picked up from me earlier this week. You could certainly be filling this out. That was the intention and what I was hoping to do during class with you. If you don't have that with you, that's not a barrier. You can fill this out in your notes or take some notes about each of the psychotherapy approaches. This stuff you could always transfer into the grid sheet or neglect it altogether if you prefer not to have those big clunky pieces of paper. But the first video will cover ones on the front side. The second video that I post today, I'll address the psychotherapies on the back side. And when I see you in class for your lesson on psychotherapies, you'll be using the information you got here in order to unpack and explore some examples of psychotherapy techniques that are being used by clinicians with their clients. So we're going to actually start with an approach to psychotherapy that you are somewhat familiar with because it's appeared in other lessons and in other contexts, like in our personality unit, for example. So we may, and I hope you actually recognize this is Sigmund Freud, because we credit him with developing one of the first cogent attempts at a school of thought in psychotherapy. So this kind of precedes all the other ones. The goal of psychoanalysis and the way that Freud practiced it was to help people become more consciously aware of unconscious content in their minds. And if you think back to our personality unit, maybe you'd recall we used the iceberg model to talk a lot about his idea of the mind and how it was constructed. He thought the bulk of our mental life was unconscious to us, and that we push into the unconscious really ugly and threatening and emotionally challenging stuff. So Freud's major idea was that through talk therapy, people could gain insight into what is in their unconscious mind. And insight just means like a better understanding of one's own thinking, a better understanding of one's mental life. Even though a lot of psychotherapy today is not driven by psychoanalytic theory, insight often remains a goal, not for all of the psychotherapies, but for most of them. And if you see someone practicing CBT today, they're still going to help you understand your thinking. They just might not be using like Freud's model of it. So insight-based psychotherapies are fairly common, even though they don't all look like Freud's. And back in our personality unit, you were introduced to some traditional Freudian approaches to psychoanalysis, because the goal is to help people become more conscious of unconscious things, particularly unresolved childhood conflicts and the like. You would see psychoanalysts, including Freud, use things like free association, where you just let the patient let their mind kind of go blank and think about anything that comes to mind. And as they're thinking about that, they're supposed to report to their analyst what kinds of thoughts are bubbling up, and without censorship. The idea being that a trained analyst could provide interpretations of the connections between the symbols that emerge in that free association content. Freud also thought that hypnosis gave people a window into their unconscious mind. Not all hypnotists today would agree that's what's going on in hypnosis, but he did make a lot of use of it before later abandoning it as a psychotherapeutic intervention. But in psychoanalysis, people are also encouraged to speak about their dreams, because an analyst would be able to help them sort through, the difference between the manifest content, the surface level meaning of the dream, and the latent content of the dream. Terms which you were introduced to in our states of consciousness unit, so that's not entirely new. a lot of psychoanalysts today, even though these kind of developed after Freud, use projective style tests to understand the functioning of their patients. So things like the Rorschach ink blot test and the TAT, both of those things are meant to provide opportunities to reveal unconscious content. So far in talking about psychoanalysis, I hope most of these concepts are seeming a little bit familiar. You've at least encountered them somewhere else this year. But your textbook also introduces a couple new terms that are specific to psychoanalytic theory. The first of these is resistance, the idea that when people are doing free association, or just speaking with their psychoanalyst to begin with, if they pause without explanation in the middle of a story, or maybe redirect and abruptly change topics, Freud took that to mean that the person was getting really close to some important unconscious content, and the unconscious is making this like last ditch effort to protect and to keep those thoughts protected and repressed. So in resistance, those are things that a psychoanalyst would want to direct a client back to. If somebody's pausing or changing subjects, they're going to say, like, hold on, it seemed like you had a thought there. What was that? To try and make sure that they get to the unconscious content that's so important. And that could also be something as subtle as a client, like some psychoanalysts interpret clients missing and forgetting appointments as not mistakes. It could be, to a psychoanalyst, they might think that means we're getting close to some of the more difficult, troubling stuff. And that's why people are, supposedly forgetting their scheduled appointments. Another thing a psychoanalyst would be especially interested in is transference reactions. Transference and the idea that that's what this is, what's going on, kind of requires acceptance of other components of psychoanalytic theory. But the idea of transference is that the patient's going to treat the therapist, who behaves mostly in a kind of neutral way. Like a psychoanalyst is trained to be somewhat neutral in their approach to kind of elicit these transference reactions. That the client may start to treat this kind of neutral person in a way that's very much like some important figure from their past that might still be part of the unconscious conflicts that they're facing. So if someone has unresolved feelings of like hostility toward their father, for example, and their psychoanalyst is a male, they might start treating that psychoanalyst in a kind of hostile way and anticipating hostile reactions toward them. That psychoanalyst is likely to bring this up at some point to the client and point out, you seem to think that I'm going to be angry with you a lot. Is there someone else in your past that you've always encountered anger from? To help the client recognize that this may be kind of an unconscious reaction to some early childhood stuff that's being incorporated into their current behavior. Now, in terms of like pros and cons of psychoanalysis, you don't find a lot of psychoanalysts, or at least people who practice pure Freudian psychoanalysis today, for a lot of reasons. It takes a long time. It's a really lengthy and time-consuming process. I mean, people can be in psychoanalysis for years. Some people benefit from that. Some people feel like the very long-term relationship that they've developed with their psychoanalyst has helped them navigate many conflicts over the course of their lives. So that's not necessarily a deficit, but certainly for insurance companies who are paying for this stuff, they're unlikely to want to pay for kind of indefinite, long-term and very circular types of approaches to psychotherapy. And of course, if you don't like psychoanalysis and its theoretical constructs, which we talked about earlier as being rather unscientific, the whole idea of the Oedipus complex doesn't have a whole lot of scientific support for it. That's kind of a deficit. Psychoanalysis also might have a kind of limited appeal. It certainly is helpful for people who want to like dig deep into potentially unconscious conflicts. Some people want to explore deeply the meaning of the things that they're experiencing, and they're going to like that. Other people are much more direct. Some people would prefer some more direct problem solving. And psychoanalysis doesn't have any kind of direct skills-based training that goes with it. But again, if you like the meaning and, you want to deeply verbally explore some important things that have happened in your life, like, psychoanalysis may be an approach for you. Now, more often, if you're going to see Freud's ideas deployed in psychotherapy today, it happens kind of indirectly. And your textbook mentions that there's this entire category of psychodynamic therapies, which are based sort of loosely on some of the ideas of Freud. And there's many different psychodynamic therapies. So for the purposes of an intro psych course, we don't go over all of them or require anybody to distinguish between them, but you might have to have some sense of what they are. So a good example of psychodynamic therapy that's practiced a good deal today is brief interpersonal therapy. And there's been a couple key contributors to this. You're seeing Harry Stack Sullivan pictured on your screen. Clareman and Weissman were a couple, actually, that did a lot of research on the use of this particular approach in treating depression. So on occasion, their names come up in relation to it. But here, the goal of psychodynamic therapies we're going to find is very different than psychoanalysis. We're still helping the patient gain insight, so the person still, we're hoping that they're going to understand themselves better and particularly understand the roots of their problems. But rather than by doing a lot of like unwieldy and, admittedly, like unplanned, like the kind of free association that may be only loosely and symbolically connected to the patient's problems, this approach focuses much more on current relationships. So a relationship with one's current spouse or significant other, family relationships, work and friend-related types of conflicts, and does go the extra step of teaching people directly some relationship skills. So this, as the name suggests, is intended to be a much briefer approach than psychoanalysis. And in that sense, it was like directly developed to correct what was perceived as an excess of psychoanalysis. Psychoanalysis is really lengthy and time consuming. This is meant to be rather time limited. The patients explore their current problems, and perhaps, the roots of those problems as they connect to maybe early childhood things. But people from this approach are trying to help the individual understand the pattern in their own functioning, and how they see other people in the world, and how that might contribute to conflicts or experiences that they're having right now. And maybe even if they need some skills, or specific strategies for dealing with them, to teach those things directly. So, for example, maybe the person with social anxiety disorder, and there actually is a good deal of evidence about this, sometimes people with social anxiety disorder feel like they don't know how to act in a given social situation. So they may have some deeply seated ideas about how other people are going to respond, and this therapy could help them explore those things. But at some point, they might need to just get some direct instruction on, okay, how do you introduce yourself to someone new at a party if you're at a room full of strangers? Let's practice that so that when you do that, you feel more confident. If you have to give a speech in front of people, let's practice that. So do some role playing or modeling to help the person develop the very skill that they're going to need to deploy in that social situation. In terms of evaluating this one, there's a lot of research evidence that this actually helps alleviate depression. So people suffering with major depression, this might be an indicated therapy if they're interested in approaching their issues this way. It certainly is less costly and less time consuming, but because of its brief course, there is some argument that maybe this is an overcorrection. Some patients' issues are not going to be resolved in 6 to 12 sessions, and in 6 to 12 weeks. And of course, it doesn't get as deep as psychoanalysis. So if that's something people are craving, maybe you're not gonna dive into an Oedipus complex in this approach. But it perhaps corrected some really important excesses of psychoanalysis. And there's a good deal of psychodynamic therapists out there today. Not all of them practice brief interpersonal therapy, but this model, even though it's building on some of Freud's ideas, which are kind of unscientific, may be helpful for some folks. Now, our humanistic therapies, we're going to bring back a familiar face as well. So as we move on to that approach, which differs markedly from Freud's, Carl Rogers back again. We got introduced to him in our personality unit, and we're introduced to his ideas about, the core conditions for growth, right? So no surprise that in his approach to psychotherapy, the whole idea is that the therapist's job is to help promote optimal growth in clients by helping them, maybe become more self-aware, because he thought the hallmark of a healthy person is that they understand their own thinking and behavior, and to promote self-acceptance. Rogers' idea was that a lot of us, through our experiences, place conditions on our own worth. Like we decide we're only worthy or valuable if we do certain things, like get A's, get an important job, make enough money, have that relationship that we wanted. His idea was that perhaps people need to learn to accept themselves as they are and understand their inherent value as a person, rather than describing it as being conditional on other things that they get from the world. So in terms of therapy and techniques that people would use in humanistic approaches, this is not a very technique-heavy way of practicing therapy, because the primary treatment modality is client-centered therapy, where the client gets to direct everything. So that's referred to as a non-directive approach, because the therapist doesn't come in with an agenda, and the therapist actually doesn't guide the client towards specific topics. Or, this is not going to be an approach where you're going to see a therapist pushing a client to talk about their early childhood. If the client thinks it's important to explore their early childhood, they're going to follow you there. But if you want to talk about something that happened today, they're going to follow you there. If you want to talk about skills or behaviors, they're going to talk to you about those things. So there's a lot of just active listening that happens in client-centered therapy, where the clinician or the therapist is listening to what the client says and then trying to summarize those statements, maybe clarify. So they might ask clarifying questions if they're not sure about the meaning of something that a client said. But there's a lot of just kind of repeating and distilling down what the client is saying. The idea is that the therapist is supposed to remain fairly neutral here. They're not giving advice. They're not telling people how to do things, because the client themselves is in the best position to figure that out. So restating what the client says helps them maybe hear it in a different way that might help them become more aware of their own pattern of thought. So a lot of the active listening techniques that you actually learn in a communications class get practiced during client-centered therapy. And of course, the client-centered therapist is supposed to project an outward stance of unconditional positive regard that hopefully would be congruent or consistent with how they're internally feeling, that they're going to assume that this client has value and they're going to hold them in positive esteem and accept them, even if they don't necessarily always agree with the decisions the client has made, because they're trying to communicate through their own behavior that you are a person of worth and you have value. So it's not required that they agree with all the decisions that the client makes, but they do have to show acceptance and support of those things. So in terms of pros and cons of humanistic approaches, this is probably not an approach that is as effective for some of our severe conditions. Active listening alone probably isn't going to help someone with a psychotic disorder or even OCD, for example. Those kinds of approaches, those kinds of conditions might need more specific techniques than this psychotherapy approach has to offer. That being said, active listening is a core part of most psychotherapeutic approaches now. Virtually all psychotherapists use Rogerian client-centered responding at some points in their work with the patients that they're treating, in part because it's helpful for letting the client express their issues in a way that's genuine, and to help them understand what they're thinking. For some people, that's enough. Like, there's a lot of people who come to psychotherapy with goals that they just want to be a better person. They want to be a better mom or dad. They want to be heard. And active listening and the like experience of unconditional positive regard from a supportive, caring clinician might take them a long way. But it is hard to be completely non-directive. I mean, this non-directive stance where you're not guiding the therapy anywhere can make this potentially a more lengthy therapeutic approach. And there may be some circumstances where you actually have to be directive. Like if a client's suicidal, for example, ethical guidelines would require that you do things to protect the client, including involuntarily hospitalizing them if they're in immediate danger. So at that point, you're going to have to break your non-directional stance. And some people feel that they need to do that even earlier. There may be some times when just listening is not enough, and you may need to do something a little bit with a little bit more structure to help the client. So this cartoon is a comic, or is a like commonly launched criticism of humanistic theory that, it seems sometimes like humanistic therapists might just be asking people about their feelings over and over again. Like people report an experience and you get asked, well, how did that feel? Tell me about that. And to be fair, yeah, that shows up a lot in that kind of therapy. But the idea is that when a client-centered therapist is doing that, it's because they are trying to make sure they deeply and fully understand the client's feelings. They're trying to experience further empathy and help the client understand themselves a little bit in the process. Okay, so the last therapy we'll go through in this video includes our behavioral therapies, and there's a whole bunch of those. Like, this is by far the most technique heavy of the therapies we're going to encounter in our brief tour of them today. But this one actually, instead of having like a theoretical father, right? So Freud being the father of psychoanalysis, here we have a theoretical mother. Mary Cover Jones gets credit for establishing the first behaviorally guided psychotherapeutic approaches. And interestingly, this treatment model, because it's based on this behaviorist perspective, remember, like, pure behaviorists aren't concerned with people's thoughts. They're concerned with visible behaviors and how you change them. So although most folks today don't practice like pure behavioral therapy, like they're not just solely operating from the behavioral perspective, if you are, it means that you actually don't really care if the patient ever figures out where their problem came from. Like, that's not an important component of this therapy. So this is one of the few therapies that we'll talk about that's really not insight driven. Like, the techniques that we're using in this approach actually aren't aimed to help people understand why they developed a specific phobia. All we care about is getting the person to approach the phobic stimulus with less fear. If you can do that, win. Like, that's the entire purpose. So in terms of methodology, as you might remember, like, the behavioral approaches have kind of three core foundational like learning mechanisms that they're using: classical conditioning, operant conditioning, and modeling or observational learning. So all of the psychotherapy approaches that are derived from this approach follow one of those same pathways. So like counter conditioning is the application of classical conditioning, where you're pairing a stimulus with hopefully a new response by introducing some other stimulus. I mean, that's what Mary Cover Jones actually pioneered. Her first published case study, or most well-known one, was in work with a boy known by a pseudonym known as Little Peter. He was very afraid of rabbits. And so to get him more comfortable with rabbits, they'd give this little boy a tasty snack that he really liked, so he could sit and eat this, and the snack kind of made him happy. But as he was eating the snack, they'd introduce the bunny, so at first very far away, just in the room with him, and that every time he was given a snack, the bunny is also introduced and getting closer and closer, they're building his comfort with it. So what's happening there is, like, he's pairing the positive reaction that he has to the food that he likes with the presence of this bunny now. So we're replacing the reaction to the bunny, which had been negative, with a more positive one because of the introduction of the food as an unconditioned stimulus. So that kind of approach underlies a lot of the exposure therapies Exposure therapies, by definition, involve exposing the client to a situation or stimulus that they have a negative response to, and that you're trying to change. One of the most clearest and systematic ways that you might go about doing this is systematic desensitization, which is often used in treating specific phobias. And it's first developed by Joseph Wolpe. So we may come back to his work later, but systematic desensitization involves several steps. So if you're working with a patient with a specific phobia, maybe they don't like dogs, maybe they had a bad experience with a dog in their childhood, we don't know, but they've got a specific phobia of dogs. So you first have the client make a list of all the things about dogs that make them nervous, and you rank them from most anxiety provoking down to the least. And so we call that an anxiety hierarchy, because you're kind of sorting these things in terms of their severity. And then you teach the client progressive relaxation techniques, like taking deep breaths, relaxing the muscles of their body, so that they can induce some physical relaxation while they're going through some of the exposure trials. And then you start at the lowest end of the list. So if their phobia was of dogs, maybe the thing that's somewhat alarming to them, but least anxiety provoking, would be just looking at pictures of dogs in a book. So you have them practice their progressive relaxation techniques while they're looking at a picture of dog in a book. If they can get through that with their anxiety being low at the end point, then you can move on to the next thing. And so you kind of go up the ladder until you get to the highest item on the list, which for someone with a specific phobia of dogs might be, being in a room with a dog and having to pet it. So being very close to one and touching it. If people can get to that point by progressively moving up through the things that they're finding unpleasant, they can overcome these phobias. And it's actually a wildly effective treatment for phobias. Most people find relief from their specific phobia while doing this. A little more intensive as a exposure therapy is flooding. That's when you just you expose the patient to the phobic stimulus or the situation that they find most unpleasant, if we're not talking specific phobias. So maybe for someone with social anxiety disorder, having to get up and give a speech in front of a room full of strangers when unprepared or something. You expose them to this stimulus at its fullest intensity. And the idea of it is that, the kind of panic response that people experience in relation to these situations can't last forever. Fight or flight responses don't last for more than 15 or 20 minutes. And if the person can stay in that situation and let the anxiety subside, they tend to have many fewer future problems with that thing. It tends to have a lasting impact because you're inducing extinction of their fear response. So the patient with agoraphobia who's afraid of going out, to stores or other places outside of their home, maybe a behavioral therapist would accompany them to those places and have them kind of track their anxiety as they're staying in a very uncomfortable situation, and have it drop. And with repeated attempts at that stuff, the client's symptoms do tend to remit. It's a fairly successful approach. Flooding, you can imagine, though, is a little bit harder sell for patients. You'd have to have a patient that wants to approach it that way because it is a little bit more of a jolt to approach the stimulus at its full force. And this cartoon down here is kind of poking fun at that. If you're trying to cure a patient of their fear of heights, enclosed spaces, and snakes simultaneously, this would be the flooding. But of course, not something that you would do involuntarily or by surprise with a client. Now, there's also a method of counter-conditioning that involves not inducing a positive reaction to a previously feared stimulus, which is our typical counter-conditioning mechanism. In aversion conditioning, you actually are trying to get the patient to have a negative response to something that they should avoid, but now currently are not. So, for example, aversion conditioning has been used with, not a great deal of success with treatment of substance use disorders. So, to have the person, each time they take a puff on their cigarette, they get a mild electric shock. That's an aversion conditioning because you would want them to then have a response to the taste or smell of the cigarette that's kind of negative, so they would avoid them in the future. Or this type of conditioning is also used in treating paraphilic conditions, so like sexual disturbances where people have inappropriate sexual attractions. They might encounter like the object of their attraction in an imagined or real way, but it gets paired with something that counters that response, so you pair it with something disgusting or unpleasant, so the person can learn a negative reaction to something that they are currently having a more positive reaction to, but maybe should not. So in operant conditioning, so counter conditioning is our application of all the classical conditioning techniques. Operant techniques include things like behavior modification, so shaping, at its lowest form. This just involves making sure that people are consistent about rewarding or not certain behaviors that you're trying to change in a person. This is most often used with children. So a child with ADHD who's having trouble staying in their seat and staying on task in a classroom setting. Teachers and parents can be trained to reinforce staying on task and doing that consistently. And to track the behaviors, like so they can show progress in getting the child to do the thing more that they need to do. But okay, that's going to require a lot of training of parents and teachers. Like all of that stuff can't just happen in a psychotherapist's office. This other approach that uses operant methods, token economies, also require a lot of intensive support within a setting. So a token economy is when you might use this in like a hospital setting or a school. So typically it's used in institutions where people are given tokens. So it could be like a literal token, like a plastic chip kind of thing, or coupons or things like that, points, that they can accumulate when they do behaviors that are desired. So if you're trying to get a very withdrawn patient with an intellectual disability to do a set of daily chores, they may get tokens for doing their daily chores, and they may be able to swap those tokens out when they accumulate enough for different privileges. So being able to, buy an extra half hour of TV during free time, or to buy things at like our school store or canteen kind of thing at a school. That's a token economy type of approach. And of course, as you might guess, a lot of behaviorists make extensive use of modeling in their therapy offices. So if a patient is trying to learn a behavior, like how to approach a social situation for someone with social anxiety, how to work through situations involving panic, maybe if it's panic disorder, client or a therapist might model that behavior. So they might demonstrate it and then have the client repeat it. That's true for behaviorists. Of course, lots of people use modeling to various degrees, whether or not they're behaviorists in therapy. But so there's lots and lots of behavioral techniques. So thanks for hanging with me through that. As we evaluate this approach to psychotherapy, let's keep in mind some things. For one, some of these things are very effective for treating our anxiety conditions. That's probably the area of disorder where these types of approaches have had the greatest impact, because the fear responses that accompany anxiety disorders, including specific phobias, are subject to classical conditioning mechanisms. So you could use counter conditioning and systematic desensitization or exposure therapies very effectively for that. Counter conditioning, particularly aversion training and aversion treatment, is used a lot to treat paraphilic conditions. The degree of effectiveness associated with that has been hard to measure because therapeutic outcomes for those folks are often hard to track. Aversion conditioning, though, may not be super effective in the long term, at least in how it's been used in substance abuse treatment. So your textbook points out, for example, that aversion conditioning for folks with alcoholism, where you put maybe some nausea-inducing chemical in their beer or alcohol to get them to avoid it in the future, doesn't seem to have great long-term impact for people outside of their treatment centers. And of course, the operant techniques like behavior modification and the token economy can be effective in shifting certain specific behaviors, but they do require a lot of intensive support and intervention. So for behavior modification, you're going to need parents and maybe teachers being very consistent in how they administer reinforcement or punishment types of consequences if those are part of it. And in token economies, like, you have to be around the patients all day. Like, so those almost can only take place in institutional settings. So like inpatient settings or in schools. Outpatient psychotherapist is not going to be able to follow around a client and reward them every time they have a positive social interaction with somebody else. So it just may not be possible in some circumstances. And some people, your textbook points this out, some people take issue with the behavior therapies because they seem a little bit more like behavioral control. Because they are harnessing mechanisms, especially in the counter conditioning stuff, that might be kind of automatic, producing automatic reactions in people. And some folks think that that might be a little disempowering, or maybe not respecting of people's humanity, treating them kind of like lab rats, maybe, which, it kind of depends on your philosophical view of things. Behavioral therapists would argue that these things are helping people and producing outcomes that people want. So even if you're using the same mechanisms that work for lab rats, if it improves people's lives, we're better off. Other folks might feel differently about it. So we'll pause it there because we'll actually stop the recording here and give you a chance to take a break. Maybe you can come back and do the other ones, the second video and the other psychotherapies a little bit later. Taking this tour of the psychotherapies today to make sure you understand these different mechanisms and the treatment approaches that go with them is going to help a lot when we're in class together again. So I'll be back with you in a second video.